Hello everybody. Today we will read about post-hysterectomy vault prolapse. Now definition. It is defined by International Continence Society as descent of the vaginal calf below a point that is 2 cm less than the total vaginal length above the plane of the hymen. The vaginal calf scar corresponds to point C on the pelvic organ prolapse quantification grade. Now, incidence. The incidence of post-hysterectomy vaginal prolapse varies from 0.2% to 43%. Now, risk factors of post-hysterectomy vault prolapse. First, pre-existing pelvic floor defect prior to hysterectomy is the single most important risk factor for vault prolapse. Second, increasing parity and advancing age. Third, previous surgery to correct pelvic organ prolapse defects. Fourth, the structures that support the top of the vagina and uterus are not reattached at the time of initial procedure. Fifth, weakening of the supports over time. Sixth, increased intra-abdominal pressure. Seventh, no correction of cystocele, enterocele, rectocele or paravaginal defect can result in other anatomic hernias and failure of the initial repair. Now, classification. POPQ system is the most comprehensive and widely used. Most vaginal cup prolapses include apical enterocele where the pubocervical and rectovaginal fascia have separated. There is always some degree of high cystocele formation and high rectocele formation associated with vaginal vault prolapse. Now, assessment and evaluation. Determine whether lower urinary tract dysfunction, sexual dysfunction and bowel dysfunction exists. Second, stress urinary incontinence may be masked in advanced POP by obstructing and kinking of the urethra. Thus, assessment for occult ACY with reduction maneuvers is done. Third, assessment of our sexual life important before management. Fourth, determine quality of life by the prolapse quality of life questionnaire. Now, prevention. First, McCall cholecystectomy. It involves the suspension of the vault into the origins of the uterosacral ligaments and obliteration of the cul-de-sac. The uterosacral ligaments are approximated using continuous sutures to obliterate the peritoneum of the posterior cul-de-sac as high as possible. McCall cholecystectomy is more effective than simple closure of the peritoneum. Second, suturing the cardinal and uterosacral ligaments to the vaginal cuff at the time of hysterectomy is effective in prevention following both abdominal and vaginal hysterectomies. Third, sacrospinous fixation. Prophylactic sacrospinal fixation at the time of vaginal hysterectomy is done for marked uterovaginal prolapse, when the vault could be pulled to the introitus at the end of the anterior vaginal wall closure. Now, management. Conservative management. First, pelvic floor muscle training is an effective treatment option for women with stage 1 and stage 2 post-hysterectomy vaginal prolapse. Second, vaginal devices. Vaginal pessaries are an alternative treatment option for women with stage 2 to stage 4 post-hysterectomy vaginal prolapse. Consideration needs to be given to sexual function, regular pessary changes, and possible complications such as ulceration, vaginal bleeding, and small risks of fistula formation. Now, surgical management. For all symptomatic patients, discuss the planned procedures, success rates, recurrence, potential complications, and the impact of treatment and potential complication on woman's quality of life and sexual function. Now, aims of surgical treatment. First, restoration of normal vaginal anatomy. Second, improvement in vaginal bulge symptoms. Third, The restoration or maintenance of normal bladder, bowel, and sexual function. Fourth, anatomical outcome. POPQ stages 1 or 0 defined as anatomical cure. Now, the surgical procedures available for post-hysterectomy vaginal valve prolapse is abdominal sacrocolpopexy, second, laparoscopic sacrocolpopexy, third, vaginal sacrospinous fixation, fourth, high uterosacral ligament suspension, fifth, transvaginal mesh, sixth, colpoclasis. Thank you for listening. Thank you.